Hello, my name is Alycia Valente. I am an assistant professor at UMass Medical School, and today I will be presenting our innovation, our medical school course entitled Health Equity in Clinical Practice. For my disclosures, I have no conflicts of interest and I'm not funded. Background for this course. So there is increased focus to teach medical students about health equity and to incorporate health equity and social determinants of health in medical school curriculum. Many existing courses focus on large-scale systemic solutions without teaching students how to affect change on the individual patient level or community level. Awareness of how to utilize existing community resources to meet patients' needs will help learners maximize health outcomes of their future patients, as well as increase health equity in the communities that they'll serve in the future. The objectives of this course. So we wanted to teach students how to define and analyze problems that patients in the ER face through the framework of social determinants of health. We wanted then to use those social determinants of health to create research and advocacy projects to promote policy change with the goal to increase health equity. We wanted these projects to focus on leveraging existing community resources and encourage students to think about both patient-focused and large-scale solutions to every problem. Methods. At our institution, medical students in their third year have a 1-week elective where they're able to explore areas of interest more in depth. This is one of those 1-week elective courses. In our course, we break it up into both didactic and clinical components. In the didactic portion, we start the first day out with a narrative piece. We use this novel excerpt to have our students identify the social determinants of health that the main character faces in order to prepare them to identify the social determinants of health in the patient story when they go into the clinical encounter later that week. We then have 2 workshops. One discusses the relationship between social determinants of health, research, advocacy, and policy, with a focus on emergency medicine specific initiatives that are going on currently and written about throughout the country. We then look at local initiatives that are going on in our communities surrounding the teaching hospital. We then go a little bit more in depth and look at the interplay between social determinants of health, research, advocacy, and policy in terms of the COVID-19 pandemic and exploring the issues that are occurring now with local, national, and international equity. For the clinical portion, the clinical portion starts on the next 2 days after the first 2 days of didactics, and it surrounds the patient interviews. So for these 2 days in the ED, we have students interview patients with a specific tailored interview guide. This guide has them write down demographic data, notes on the patient's story, and then have them identify the social determinants of health and other barriers that the patient faces that contribute to their ED stay during that time. We then ask them to identify immediate, short-term, and long-term solutions and identify potential organizations or resources that could help them in real time. We then, on the day after, analyze patient encounters more in depth and develop project-focused solutions. On this last day, we reconvene to determine if the barriers to patients they saw in the ER the 2 days before were individual to the patients or more generalizable to communities that we see in the ED. We then focus on existing organizations and policies to look for solutions to these problems, and then brainstorm both local ED implementable solutions, as well as more pie-in-the-sky regional and national solutions to these problems. For our outcomes, 3 students completed this course at the time of our innovation submission, and now we have 5 students that have completed this course. The students all stated they liked hearing other student perspectives, and they also described feeling empowered. Students elaborated that learning about the health inequities that existed, they felt sort of powerless to help their patients in the future. And now they had a little bit of a better understanding and a toolkit to enact change with their future patients. All students wanted more ED time to further understand ED culture and tailor their potential projects. This was tough because when we rolled out this course, it was during the COVID-19 pandemic, and students were limited to the patients they were allowed to see secondary to hospital policy. They could not see PUIs. So in summary, this course allows students to recognize the ED as an integral extension of the community. It focuses on community resources that exist to implement them in real time. We also develop small-scale achievable projects that the medical student can then work on if they choose later on in their medical student career. And we also encourage them to brainstorm larger scale solutions. And with these solutions, emphasize elevating voices of affected members of the community to enact policy change, as well as collaborating with community resources and community voices for sustainable project design and solutions. So the strengths of this course: it's a very small size. We only have 1 to 2 students per course, and that allows for really great discussion. We also have an impersonal clinical experience component, which improves learner comfort with the application of these topics. And there's also a single facilitator, so we're able to be adaptable and flexible to individual learner needs. The limits are, these are very nuanced discussions, and there's limited facilitators to guide the discussions. Thank you so much. I appreciate this opportunity, and I welcome any questions.
Hello, hello. Hi, my name is Dr. Joshua Ellis, and I'm here to present a novel curriculum that we developed titled Racial Disparities in Emergency Medicine. First and foremost, no financial disclosures. However, I do have some obvious biases. I'm a half Black and half Mexican-American male, and I'm a first-generation college student and the first in my family to go off to college. And while this lecture is about biases and racial disparities, I wanted to present my own biases with relation to this and be upfront about them. And hopefully you guys can appreciate them. We actually used a Kern 6-step approach to curriculum development to develop this curriculum. And this always begins with step 1, problem identification. And most of us have been able to identify the problem, particularly when it comes to patient outcomes, right? We have decades worth of literature to suggest that we have continuously had poor outcomes for African-American or underrepresented or minority patients, depending on which statistic. And what was shocking to me as I went through this details myself and studied this material to present it is not only the magnitude, but also the variety and the insidious ways in which biases can creep into our management and care delivery process. But more importantly, also the resilience and persistence of them. Many of these studies have been replicated after 2 decades and have shown no improvements or changes in outcomes. The next component to the identification was educational outcomes. This is actually a survey taken in 2019, which demonstrated that half of white medical students and medical trainees at the University of Virginia actually believe myths such as Black people have thicker skin or less sensitive nerve endings. And this would also suggest differences in the way we're prescribing opiates or pain management that we've been able to demonstrate with patient outcomes. But this is an educational outcome in which we can survey the knowledge gaps inside our medical students. Furthermore, we've also identified subconscious bias, as many of these papers in literature in the health disparities movement have been able to eliminate enough confounding factors to where they can attribute subconscious bias as one of the reasons we're having these differences in outcomes. But we actually don't need this, right? If we surveyed emergency medicine physicians, most of us would say that we actually have biases related to race. And here's a chart here of a survey of such. And not to be confused, this is actually isolating the race of the physician, not the patient. So regardless of race, the majority of physicians still believe that they are perpetrating or having biases in their practice. Another part of the problem identification we looked into was the physician race demographics. Now, anecdotally, I understood that there was a disparity. However, it took understanding the data, how severe this disparity is and how little we've improved over the last several decades. So we're 13.4% Black in the United States as a population, and then the physician workforce is only 5% Black in the United States. Furthermore, medical students are only 7.3% Black, so we're nowhere near on track to reach population parity. And if you take a look into our historic data over the last several decades, we're actually not doing that much better than we were several decades ago, especially in relation to affirmative action policies and everything. Our next step was a targeted needs assessment. And our targeted audience, actually, we had to identify were third and fourth year clerkship students coming through the Beth Israel Deaconess Medical Center's emergency clerkship program. And this included all Harvard medical students in their third or fourth year that would be taking this clerkship, and any visiting clerkship students as well. In addition to this, most governing bodies in medical education have also dictated and released statements suggesting or prioritizing the need for health equity, social medicine, education. This includes the ACGME, AAMC, and CORD. And so with this identification, we've already done the problem identification. We're actually easily able to come up with the goals and objectives, which is the third part of the Kern model. And so first and foremost, we wanted to provide examples of the magnitude and variety of health disparities, right? And then we went through the process of subconscious bias and the implicit association test. And then we went through previous implementations and current implementations that have been shown to mitigate the impact of these disparities or the disparities themselves. And then lastly, we described this process and status of racial diversity in relation to medical education. And now our educational strategy was another part of the model. And what we ended up doing is relating to a paper here written in the Journal of General Internal Medicine, which actually looked at qualities of medical schools or attributes of medical schools that were associated with lower incidences of bias amongst their students. And what this paper concluded was that having a longitudinal or integrated health disparities curriculum and also a non-accusatory healthcare curriculum were two of the 5 utmost reasons that they found were attributes of medical schools with good lower incidences of bias. And we were really gravitated toward the longitudinal and integrated. And so we present a racial disparities curriculum specific to emergency medicine during the emergency medicine clerkship, integrated into its clerkship. And then furthermore, it was non-accusatory. So we considered doing simulation or small group, but we found this to be very difficult. And so we went with the lecture format where we could get the most information to the student in the most comfortable way possible. And step 5, implementation. We actually studied this data and hope to make a paper out of it. So we had to obtain an IRB exempt status. And in order to do so, we really had to work at de-identifying the recipient and also giving them a true opportunity to opt out of the research and do so anonymously. And as far as implementing the clerkship, we ended up doing this on the weekly simulation days, which was actually quite easy to do and easily feasible. And step 6, evaluation and feedback. And so we've actually had a difficult time even assessing how do we measure the outcomes and evaluate the efficacy of a health equity curriculum. It would be unfeasible to go and look at the patient outcomes of the individual medical student and think that a 30-minute lecture had anything to do with changing them. But furthermore, simulation would also be unfeasible, although we did look into getting potentially an African-American standardized patient, but still, once again, unfeasible and likely very accusatory. And so we went with the multiple choice pre-test and post-test. And in developing these questions, we actually had a hard time as well. We found we wanted questions that were unguessable. In other words, racism is usually always the answer in these. And then not too statistically heavy, right? And one of the questions we actually came up with was an example: African Americans make up 12.7% of the US population, but only 7.3% of medical students. And this is something that we wanted them to be able to retain after having the lecture. So data collection so far, first and foremost, they like it. We gave them a Likert scale on the day of the curriculum, and we have actually had an overwhelming positive response. 80% have agreed with all statements, and the statements being enjoyable, important, non-accusatory, and potentially changing clinical practice. And furthermore, we actually had a significant improvement on the pre and post test, a demonstration of knowledge. And we actually gave them the pre and post test 3 weeks apart. And so a retention of knowledge was also important. We had an average increase of 25.7 on the test. And so all in all, we're excited that we're continuing this process. They're learning from it, and we're planning to continue to implement this curriculum to all clerkship students and also in residency didactics. Thank you guys so much for my talk. And if you have any more questions, please feel free to email me.
Hello, my name is Alexa Lucas, and this is my colleague.
Hi, my name is Alejandro Avina-Cadena.
And we are presenting on the Structural Competency Curriculum, a novel approach in medical school education for addressing the impact of upstream structural issues on patient health and healthcare delivery. We have no financial conflicts of interest to disclose. The social determinants of health have historically taken a backseat in medical education. Those individuals with stronger interests in health inequities and health injustices have inconsistent opportunities for further knowledge acquisition in this area. Our experience with social determinants of health education in the past 4 years has been minimal. During MS1, we had some lunch talks. Some of us attended conferences as second years. During clerkships, a group of us would discuss our experiences during each rotation. And as students prepare for residency, they may seek out programs with a strong social justice emphasis. Studies have shown marginalized communities have poor health outcomes. And although there have been successful attempts at weaving social determinants of health education into medical school curriculums, they have typically been done inconsistently, only exposing certain groups of students to more in-depth curricula or reaching a broader audience during a short portion of their medical education. There is a need for a longitudinal curriculum that spans the entirety of undergraduate medical education. We developed a 4-year longitudinal curriculum that addresses structural injustices within our current healthcare system and how they have given rise to social determinants of health. Our hopes are to create a comprehensive medical education for UC Irvine School of Medicine, leaving it a better place than when we matriculated, so that future students can utilize these adaptations to the curriculum as a platform from which they can feel welcomed, feel heard, and thrive.
We've identified unique opportunities to integrate social determinants of health education into every year of our medical school. The MS1 and the MS2 curriculums are actually fairly similar. During the first year, the students received 2 lectures, one, an introduction to social determinants of health, and another on the introduction to vulnerable populations. This is followed in their second year with a lecture on racial and health inequities. In addition to the lectures, we've collaborated with our Clinical Foundations course, our CF course. This is our How to Doctor course at UCI. We've integrated 5 social determinants into CF1 and 6 into CF2. This was all done by editing our standardized patient scripts and providing each preceptor with review slides. This is an example of one of our edited patient scripts. Everything you see in red is our edits. We changed the story from a waitress with a stable job and health insurance to an incarcerated patient working in the prison kitchen. This is a different case, but it does represent an example of the PowerPoint slides that we provide each case preceptor for the CF course. The 4th year of curriculum was adapted from previous work done by Moffitt et al., and it was implemented within the 2-week and the 4-week emergency medicine rotation. UC Irvine medical students, as well as visiting students rotating with us in our ED, were asked to complete a 3-part assignment. First, students are asked to choose a patient to have a conversation with. This isn't intended to be an exercise in acquiring a medical history. Rather, this conversation is for the student to learn about that patient's life. Second, students are asked to synthesize their conversation and identify at least one social determinant that may have played a role in that patient's well-being. Then they're paired up with that patient's case manager or social worker in the ED to review any of the social determinants that may have came up and brainstorm some possible resources. Third, students are required to write a short reflective piece on their experience, what they learned, how it made them feel, how it impacted their views on social determinants, etc. In addition to these 3 assignments, students enrolled in the 2-week EM clerkship are given the opportunity to complete an extra assignment to qualify for honors. From their interdisciplinary conversation with the case manager, students are tasked with choosing one factor to utilize in developing an infographic to display the most relevant resources they came up with. This infographic was made to address food insecurity. It's an example of what we expect our students to make. In addition to providing free online resources to create their infographic, students are given a rubric of what we expect their infographic to look like. This includes having it be visually appealing, including a minimum of 3 points of information, and overall it should be fairly easy to read.
The curriculum is in its first year of implementation, so data is limited. However, responses from students have been overwhelmingly positive. In the Introduction to Social Determinants of Health lecture, 97% of students strongly agreed that the session was effective, with students stating that this, quote, pushes us to do and be better. The MS2s have just finished the first year of the curriculum, and we're currently developing the MS3's curriculum. For the 4th year emergency medicine clerkship, we have had about 36 students respond to our initial feedback survey, and 92% were either very satisfied, slightly satisfied, or satisfied. One student even stated, the assignment pushed me to ask questions I normally wouldn't have and better understand why my patient keeps coming back for drug intoxication and pain management. I also learned a lot from speaking with the social worker.
So this curriculum is a passion project of ours. It began as a lack of socially determinants of health experience over the past few years. However, we recognize it's not perfect and we still have a lot of work to do. To ensure sustainability of the curriculum, we both signed up for the medical education teaching elective at UCI, where we're learning a little bit more about adult learning theories. We also hope to ground the curriculum in theory, aligning it with the health belief model and the social cognitive theory. Some of the more immediate changes we'll be making include collaborating with the College of Health Sciences to put together a complete list of all student-led health equity, anti-racism, and health policy curriculums. The goal of this collaboration is to see if we can harmonize all of these efforts within a single curriculum to minimize overlap and redundant efforts and maximize the degree of which these components can build on each other. We're currently working with the clerkship directors for all 30 rotations to develop an integrated case-based discussion, focusing on a unique socially determinant of health for that rotation. And lastly, we'll be using feedback surveys to improve our emergency medicine curriculum.
We're all very excited about the success of this project thus far. We would like to thank Doctors Sakria, Sudario, and Ray for their support in developing this curriculum, as well as our fellow colleagues that contributed to this project. We look forward to answering any of your questions.
Good evening. I'm Dr. Ashley Pavlic, and I have the privilege of presenting with you today on some curricula we've established on vulnerable patient populations and social determinants of health. We have no disclosures. It's become increasingly apparent that a biomedical disease model is no longer sufficient to really treat our patients effectively, that what we really need is a biopsychosocial disease model, one that takes into account patients' social determinants of health, which are the psychologic, social, and environmental factors that impact a patient's health outcome. These include things like reading level, access to transportation, and access to fresh foods. This is all rooted in the questions of how do we provide better medical care and how do we empower our learners to provide better medical care. 2 years ago, Dr. Sonnenberg and myself established a division of global and population health within our department and also started the DOORS curriculum, which was infused into our resident and faculty conference. DOORS stands for Developing an Outlook on Other Realities. Last year, we started a 4th year medical student elective that was 4 weeks long on population health in the emergency department. And this year, we are establishing a social emergency medicine track for our residents. The mission of these is to understand the doors that our patients come from so that we can provide better medical care. Many of these are doors that you and I do not frequent or maybe have never been through. Specifically, it's to recognize when social determinants of health are at play, that perhaps non-compliance or chronic abdominal pain with no diagnosis is actually a psychosocial issue that if we would ask about, we could actually do something about. Also to give our learners the scripting and the practice on how to actually do these assessments. A huge tenet is to increase empathy and compassion by really understanding where our patients are coming from and kind of breaking down the walls between us and them. And then finally, always a very practical approach. We want our residents to know what the resources, both in the ED and the community, are and how to connect the patients with them. When we first started the curriculum, we got some baseline demographics on our residents and found that they were mostly white, mostly from middle and upper class families, and had very educated parents. We then asked them, how much interaction do you have with various populations that we see in the emergency department in your own personal life? And in here, the lighter blue and the red means never or very rarely interact with these populations, which you can see as most of the populations here. Then we asked, are you familiar with the ED resources for these populations? And the 2 red bars are strongly disagree, not familiar, or disagree. And overwhelmingly, our residents did not feel that they were familiar with the resources available. We then took that information and targeted specific resources and specific vulnerable patient populations. We also have some general lectures on health equity and social determinants of health. After the curriculum, we found that the resident support stated that they had a statistically significant increase in their understanding of the resources available for several of the populations that we targeted. It went well, so we were asked to expand, and last year got some dedicated time because national conferences weren't happening to do a full day with our second years on some community engagement experiences. So we had 6 experiences, both virtual and in person, and these included, for example, a virtual tour of a homeless shelter and an in-person tour of the Department of Corrections. The residents loved it. We also last year started our 4-week elective on population health in the emergency department and had several of our residents involved, including Dr. Khan, Dr. Kenzie, and Dr. Lipinot. This started with a simulation session run by Dr. Crow and Dr. Sonnenberg and myself, in which the students actually got to practice doing a social determinants of health assessment. Then the students shadowed a patient in the emergency department from the time they checked in throughout their whole course. So they really got to see from the patient's perspective what the emergency department is like. And then we had 1 week deeper dive on poverty and homelessness, victims of violence, and mental health. That went well also. And the residents who helped us with that came to us and said, you know, we're really interested in devoting more time to this. You know, we're in the process of establishing a global health track, and the residents came to us and said, you know, we really want a social emergency medicine track. So we said, great. We learned some lessons, including that introduction lectures are a bit challenging. Residents come in with different levels of knowledge about topics like these. And also lectures can be a little bit dry. So next year we're going to do this in small groups, the introductory content in small groups. We also learned that the talks went a lot better when the speakers were well educated, that this wasn't about just giving data, but was really about visualization and narrative and storytelling, really coming to understand different populations. And then small groups and interaction were always best. For the M4 elective, because everything was compressed, it got a little heavy. And so, for example, at the end of the Victims of Violence Week, we got the feedback that it was, our students were really feeling down. So in future years, we're going to figure out how to break that up a little bit and then also include some content on second victim syndrome. And we also originally positioned the elective during interview season, thinking that we could make it really flexible, but found that it's much better when the students are all together and can learn from each other and mentor each other and interact with each other. So we're going to move it out of interview season for next year. Whenever possible, we do emphasize that, you know, doing this, really being good about social determinants of health and thinking through care with our patients, it's good for them and it's also good for us. It helps us and counteracts burnout to really feel like you're making a difference in our patients' lives. And then additionally, if you can stop the cycle where patients aren't returning to the emergency department for, you know, avoidable things, then that's good for everyone too. In the future, we'll have more content and include simulation sessions where social determinants of health are part of the point of the case, because really it should just be all integrated. We should be doing this with every patient encounter. We have an expanded community engagement day for our interns, and then also are very excited to develop that social emergency medicine track, a deeper dive, and it really empower our learners to be leaders in this area. Thank you so much.
Hi, my name is Rehman, and I'll be talking today about the use of social simulation to advance health equity and improve physician well-being. There is growing literature on the relationship between physician burnout and perceived disempowerment when serving vulnerable populations. This is particularly salient in the field of emergency medicine. As safety nets for medical care, emergency departments encounter patients with complex healthcare needs that are largely influenced by socioeconomic factors. Factors that characterize emergency departments, such as a fast pace, limited information, and high acuity, all necessitate rapid clinical reasoning and decision-making. The subsequent heightened reliance on cognitive biases interacts with classism, racism, and sexism to exacerbate disparities in patient care. Despite the tremendous need, there is still a dearth of formal training on structural determinants of health inequity. In response, we designed an intervention that integrates simulation learning and developed cases on social needs commonly encountered in our emergency department. In addition to advancing innovation in social simulation in medicine, this intervention also includes interdisciplinary stakeholders, such as care managers, community health workers, and social workers in the attempt to overcome barriers in ED operations when addressing structural determinants in complex and critically ill patients. Starting in the fall of 2019, we started to develop cases addressing commonly encountered social needs in our emergency department. For each case, we established objectives, a patient identity card, a guided script, debrief questions, and teaching points. Ultimately, we selected 6 cases to minister in our pilot of the simulation for residents. Residents from all 3 years in our program were randomly assigned to 6 groups that rotated through 6 different cases. Each case simulation took place for 5 minutes. Pre-assigned facilitators moderated a debrief session after each case for an additional 5 minutes. After all groups rotated through 6 cases, a final debrief session for 50 minutes was held. This final session entailed a moderated discussion with interdisciplinary team members, reflecting the fields of care management, community health work, social work, and trauma-informed care delivery. The goal was to utilize the gathered information and insight to inform a more streamlined protocol to address social needs in the ED by thinking critically about how we can re-engineer clinical operations and optimize existing information exchange systems with community partners. A 9-item instrument with responses on a Likert 5-level scale assessed participants' knowledge and skills pertaining to structural determinants of health before and after the simulation. A non-parametric statistical test, the Wilcoxon-Sign rank test, was used to assess for significant changes pre and post intervention. An inductive or open coding process was utilized to perform the qualitative analysis of the large group debrief. Prior to the intervention, all residents agreed or strongly agreed that they understood how social needs can serve as barriers to their patients' ability to access healthcare. The majority of residents also agreed that addressing their patients' social needs in the ED made them feel empowered and gave them satisfaction. However, only 17% of residents agreed that they could differentiate between the roles of interdisciplinary staff members, and 33% of residents agreed that they could identify their patients' social needs. We found statistically significant differences in self-reported ability to identify patient social needs, differentiate between the roles of interdisciplinary team members, and knowledge in how to work with them. There were also statistically significant differences in self-reported ability to identify hospital resources patients could be referred to, an agreement that addressing a patient's social needs in the ED makes one feel empowered. For the latter, the table belies a significant increase in number of participants who strongly agreed in particular. The qualitative analysis of the large group interdisciplinary debrief yield the following themes. Discussion of behavioral health focused on limited capacity of inpatient psychiatric units, provision of trauma-informed care, and caring for patients with substance use disorders. With respect to substance use disorders, there specifically was discussion on outpatient resource referrals, inpatient medically managed withdrawal units, and initiation of naloxone in the ED. Discussion on financial insecurity focused on housing instability, food insecurity, and improving affordability of medical care and treatment. Specifically, information was shared on assistance with securing government resources such as SNAP, placing high-risk patients in stable housing, and directly providing patients with resources such as food, clothing, and prescription coupons. Discussion on access to care focused on helping patients navigate a complex healthcare system when scheduling appointments with primary care physicians and specialists, facilitating care for uninsured and underinsured patients, and understanding how language barriers impede care coordination. Discussion on health literacy focused on preventative medicine education, such as on diabetes and asthma, differential medical capacity and scope between different healthcare settings, such as the ED versus urgent care versus outpatient clinic, and how to express one's medical concerns to the health provider team. Finally, discussion on community partnerships centered on building trust with marginalized communities to preserve a culture of accountability, in addition to the technical aspects of integration with community-based organizations into the EHR workflow, such as through the NowPow database to facilitate closed-loop referrals. Potential limitations include the lack of a control group, the self-reported nature of the data, and the presence of significant missing data from the final analysis secondary to unmatched responses. Additionally, potential effect modifiers, such as a year of residency training, were initially identified. That data was not collected to preserve anonymity in the setting of a small sample size. There were several facilitators to implementation of the simulation subsequent social need protocol. One was an increased interest in minimizing boarding in the ED and inpatient hospitalizations amidst COVID-19 patient surges, such as through investment in structural redesign of hospital units to expand inpatient psychiatry capacity. Additionally, there were existing multidisciplinary teams who we could work with to address our patients' social needs. At the same time, there were several barriers, such as necessary task shifting of interdisciplinary staff members during the COVID-19 pandemic and limited capacity of community partners amidst concurrent increased demand of resources. Additionally, the simulation and social need protocol were being designed and launched at the same time as implementation of a new electronic health record during the COVID-19 pandemic, which still does not include an automated process of placing our care managers or community health workers on consult. This pandemic is not going anywhere. An increasing number of people will become unemployed and uninsured. There are looming big cuts in funding for hospitals and public health departments, just as the need is substantially increasing. Now more than ever, physicians will need to become better equipped to navigate limited resources with interdisciplinary partners. Ultimately, improving our capacity to address social needs in the ED has the potential to both improve patient care and safeguard physicians against further burnout. This work would not be possible without the investment of so many people at our hospital, for which I am very grateful. Thank you so much.
Hello, my name is Amy Zosel. I'm an associate professor of emergency medicine and medical toxicology at Medical College of Wisconsin. Thank you for attending this innovations presentation of Intervention to Increase Nomination of Women Faculty for Awards to Promote Professional Development. I'd like to thank my collaborators, Mary Beth Phelan, Colleen Crow, Christy Meso, Jennifer Hernandez-Meyer, Claire Becker, and Charlie Ann Rickwalder. These authors have nothing to disclose. In 2018, more women than men applied to U.S. medical schools, comprising 51% of applicants. Women were also the majority of matriculants to medical school for the second year in a row. In spite of the greater number of women entering the medical profession, consistent data show that there's an inequity in the advancement of women in academic medicine compared to male colleagues. Women are less likely to advance to senior positions and have been found to have lower salaries than men. In a study of academic pediatricians, women were less likely than men to be promoted to full professor in spite of being more engaged in teaching and patient care. In a recent study published in Women's Health Issues in 2016, it was found that many U.S. medical schools have no programs supporting gender equity among faculty. Medical schools that have programs focus more on interpersonal and individual level skills, such as training and unconscious bias. Multi-level efforts are needed to more effectively advance the careers of women in medicine. As national recognition, which may include awards, is a necessary component of promotion to professor, we aim to increase the number of award nominations and awards received by female faculty. The objective of this project was to implement a workshop on award writing for female faculty to improve perceived competency and willingness to nominate female colleagues for regional and national awards. Our primary outcome was self-reported improvement in perceived competency and willingness to nominate female colleagues for regional and national awards. The secondary outcome is still being evaluated and includes the number of regional and national award nominations for female faculty in the Department of Emergency Medicine. During a professional development activity for female emergency faculty members, a need was noted for recognizing and promoting female colleagues. For promotion in academic medicine, a regional and national reputation is necessary. A gap of knowledge of how to write nomination letters by several female faculty members was identified. In addition, it was noted that learning of such awards usually involved an email received passively by a faculty member. In other words, there was no centralized place to search for potential faculty awards for women. A work group of female faculty were tasked with creating a process by which female faculty would be nominated for regional and national awards. A toolbox was created, including an easy-to-navigate list of potential awards for female faculty with a brief description and a link to application websites. The toolbox also includes examples of letters and a PowerPoint of gender bias awareness and letter writing. The nomination process is tracked using an Excel sheet tracking tool, including the name of an award, nominee, nominator, and outcome of nomination. The toolbox was presented at an award writing workshop. Female faculty members were surveyed pre- and post-workshop to assess differences in awareness and self-reported improvement in perceived competency and willingness to nominate female colleagues for national and regional awards. Elements of the award nomination letter writing workshop included a presentation that focused on avoiding unconscious bias in letter writing, an introduction to the toolbox, a discussion around specific nominations and awards, and a survey. The toolbox includes several important resources meant to support award nomination letter writing and the tracking of nominations, including a list of available awards with nomination criteria and submission timelines, an award tracking spreadsheet with a brief description of an award, the writer and recommended individual and status of the award, and a link to the application, examples of nomination letters, and writing resources. A total number of 11 participants were surveyed pre- and post-workshop. All participants strongly agreed when asked if, as a result of this workshop, I would be more willing to nominate a female colleague for an award, and this workshop was valuable. After the workshop, there was a significant increase in agreement with the statements, quote, I feel comfortable writing award letters for other female faculty members, end quote, and, quote, I feel confident that I understand what it means to write an award letter that is free of gender bias, end quote. P-values 0.03 and 0.01 respectively. After the workshop, 100% of the participants strongly agreed with the statement, it is important to promote female faculty, and 100% agreed with the statement, it is important to write award letters for advancement of female faculty. In conclusion, a targeted educational intervention workshop and toolbox was created using an easy-to-navigate list of potential awards for female faculty with a brief description and a link to application websites, examples of nomination letters, and a PowerPoint presentation of gender bias awareness in letter writing. Pre- and post-survey results revealed self-reported improvement in perceived competency and willingness to nominate female colleagues for regional and national awards. This has potential implications to increase the regional and national recognition received by female faculty, making them more competitive for promotion and advancement. Next steps include tracking award nominations and received awards, as well as expanding award letter writing workshops. Thank you so much for your attention, and I'd be happy to entertain any questions at this time.
Hi, everyone. My name is Tomas Diaz. I'm a medical education fellow at the University of California, San Francisco, and I am very excited to share with you a critical race theory curriculum for emergency medicine learners, which I created and subsequently facilitated with my co-author, Star Knight. To begin, I have no disclosures. And what was our motivation for this project? Whereas the suffering of white communities has been medicalized, healthcare in the United States has long disregarded, criminalized, and exacerbated the suffering of communities of color, particularly Black communities. Furthermore, racial inequities have been identified within the academic medical environment, including medical student evaluations, NIH funding, and faculty promotion processes. Academic medical centers shoulder the responsibility of addressing health inequities and creating environments where Black students and faculty members can not only survive, but thrive. The murder of George Floyd in May 2020 led to renewed and increased awareness of longstanding racism and anti-Blackness in the United States. In this setting, various medical institutions released statements condemning racism and committing to incorporating anti-racist content into their curricula. This constitutes a major shift, as historically medical education has emphasized a biomedical approach with focus on pathophysiology over the social and structural determinants of health. And what is critical race theory? Critical race theory, first introduced in the 1980s within the legal field, provides a race-conscious framework with which to examine inequity, power, and justice within a given social structure. More specifically, what are some of the tenets of critical race theory? This list is by no means exhaustive, but I think it is important to explicitly lay out the basics of what underlies this framework. 1, the ubiquity of racism. 2, skepticism of dominant narratives. 3, humility. 4, intersectionality. That is the recognition that our racialized experiences are mediated by other social identities. Elimination, and 5, elimination of racial oppression as part of a larger project to eliminate all forms of racial oppression. Ultimately, critical race theory is a theory that guides action from conceptualization to implementation to evaluation and reflection. With our curriculum, we aimed to help learners identify personal and emotional responses to racism in the United States, to become familiar with the basic tenets of critical race theory, to understand how historical constructions of race have shaped systemic racism today. You know, we need to know where we came from to understand where we are and where we might go next, and to apply a critical race theory framework to issues relating to emergency medicine, which I think is the fun part. 15 incoming EM interns at UCSF were invited to participate in the curriculum on a voluntary basis, and ultimately 8 learners completed the curriculum. All sessions were facilitated by myself and Star Knight. We both have experience guiding workshop discussions related to topics of race. Prior to each session, learners were provided pre-session materials which did not exceed 2 hours of work. Materials were curated to provide foundational knowledge on critical race theory and US history, as well as local histories of racism and activism in the San Francisco Bay Area. Here's an example of the curricular content. This is from session 3. I don't mean for you all to read the specifics of this slide, but I do want to point out that in the middle column, you can see the pre-session materials, which include podcasts, a book chapter, and a couple of articles. The rightmost column has guiding questions to frame participant engagement with the material, and this was intended to make the material feel less intimidating. Pre and post curriculum surveys asked respondents to select responses on a 7-point Likert scale. Questions related to comfort, motivation, and analysis of issues of race and racism, as well as familiarity with critical race theory. As shown, despite a low statistical power, survey data may suggest increased comfort and sustained motivation discussing topics of racism among participants. There was also a statistically significant increase in familiarity with critical race theory among participants, and learners were nearly significantly more likely to report having a framework for analyzing topics of race and racism, which I think is incredibly important, obviously, for engaging with these and other related topics in the future. The thematic progression and editorial choices were viewed favorably by participants, as well as the semi-structured approach to facilitation. The participants, true to emergency medicine, were eager to begin action, but ultimately appreciated the theoretical foundation upon which to develop an action plan. Narrative feedback pointed to challenges of covering all of the material in the time allotted for each session, and identified the different knowledge levels of different participants. Some of the strengths of the curriculum: opt-in participation and small group size contributed to a very engaged cohort. The virtual format made attendance less burdensome for participants. Semi-structured facilitation allowed participants to guide conversations to their own topics of interest while also addressing the larger topics of each session. Independent guided pre-work allowed participants to gather knowledge at their own pace prior to each session. And because this curriculum emphasizes critical analysis and engagement over fact-based knowledge, it's broadly applicable even beyond graduate medical education to other health professions education as well. Our data analysis is limited by the small cohort size, but additionally, implementation of this curriculum also requires facilitators with expertise and experience guiding workshops on race-related topics. Our success with the virtual format presents the opportunity for programs and institutions with limited numbers of qualified facilitators to collaborate with other institutions to enact this type of curriculum. Several project ideas were born out of this curriculum. I'm hopeful that with 4+ years at UCSF, this group will make a big impact. Moving forward, Dr. Knight and I will be incorporating the feedback from this cohort of learners to engage our second cohort in June. And with that, I thank you for your time, and I look forward to further discussion during the Q&A.